And now I'm excited to introduce Dr. James Burton. So I'd ask him to start sharing his slides now. So I have had the pleasure of working with Jay for, I think, actually almost 10 years now, if you include training. And Dr. Burton is an expert in all things liver. And he will be talking, he is our medical director of liver transplantation here at the University of Colorado, and he will be giving us the updates on living donor liver transplantation.
Thank you, Amanda. Can you see my slides?
I can. Take it away, Jay.
All right, so I'm going to give you an update in living donor liver transplantation and some things we're doing here at the University of Colorado. I do not have any disclosures related to this talk. So today's objectives here, I'm going to talk about the role living donor liver transplant has for your patient who needs a liver transplant. We'll talk about a unique aspect here at the University of Colorado, our non-directed living donor liver transplant program, and also a little bit about our number of patients we've transplanted who are double donors, who have donated both part of their liver and a kidney. And I'm going to discuss the impact this has had on our colleagues over at Children's Hospital's pediatric waiting list. So what is living donor liver transplantation? Well, this initially began where a donor, a healthy person, would donate part of their liver to a recipient in need. Their entire liver is removed. This started out in children with left lateral segments where 15 to 25% of a normal liver was removed and given to a child. This increased as experience was obtained. Left lobe liver transplants were performed where 30 to 40% of the liver volume was removed and given to a recipient. It was here in Colorado, actually, in the late 90s where the first adult-to-adult right lobe living donor liver transplant was performed. And this is where you're taking 60 to 70% of a normal donor liver and giving it to an adult, and a larger adult. Now, this is a major operation, and it does carry some risk associated with it. Risk of death with doing a left lateral segment or a left lobe liver transplant is about 1 in 1,000. The reported estimate of risk of death for a right lobe living donor liver transplant is about 1 in 250. As with any major operation, the risk of complications is not low. And if you look at any single complication, whether it be a wound infection, a DVT, anything at all, the risk with a right lobe living donor liver transplant is about 30 to 40%, though that risk is much lower in a left lobe or a left lateral segment. So why should people consider living donor liver transplants? Well, in the United States today, 1 in 5 people die waiting for a liver transplant. So if you need a liver transplant, you have about a 20% chance of not receiving one and dying. So one of the advantages of living donor liver transplantation is that it frees the recipient from the allocation system and the wait list. And for every person that gets a live donor liver transplant, there's another deceased donor liver that's available for someone else. It allows someone to get transplanted before they're critically ill. And so instead of being stuck in the ICU on dialysis and sick as snot, you can get transplanted earlier, and that helps with your recovery. It's an elective surgery. It's actually scheduled, and that allows you to optimize timing. These are healthy organs. I mean, the donor goes through an extensive evaluation, so we're talking about a very healthy liver, and the ischemic time is very low because the donor surgery is being done next door in the next door operating room, and the liver is just carried across the hall as opposed to being flown across the country. And most importantly, there is equivalent survival compared to deceased donor liver transplantation. This has the comparison of live donor liver transplantation with deceased donor or cadaveric transplants has been looked at in North America. And once you adjust for the severity of illness, there's no difference in mortality or graft function or failure between the two modes of transplant. Now, as many as you might know, people are ranked on the transplant list based on the model for end-stage liver disease score. And this score predicts one's survival or their death in the next 3 months while they're waiting for a liver transplant. So if you have a MELD score of 40, you have about a 90% chance of dying in the next 3 months. If you have a MELD score of 26, you have about a 20% chance of dying in 3 months. And in Colorado, most transplants are performed between MELD scores of 29 and 40, which is about a 25 to 90% chance of dying in 3 months. Now, the minimum score, a MELD score, for someone to get a living donor liver, or to get a deceased donor liver transplant, is a MELD score of 15. If you have a MELD score under 15, you are not going to be offered a liver transplant. And where does that come from? Well, this was looked at back about 15 years ago, and this slide compares the mortality risk of staying on the waiting list versus the risk of having a liver transplant. And I always tell people having a liver transplant is a major operation and it can kill you. If your MELD score is under 15, in general, and this is 15 years ago, you have a better chance of staying on the wait list and not having a transplant, because your risk of death is actually lower than that of having a transplant. But once your MELD score gets above 15, in this study 18, it was the threshold where you started to see a benefit, your risk of death starts to increase, and it's better for you to get transplanted than to stay on the waiting list. Now, the survival benefit of living donor liver transplant in the era of the MELD score has been looked at, and this slide actually looks at time zero is the time at which people had donor evaluations. Not everyone finds a donor, and some people do. But this slide shows that if you have a living donor liver transplant, whether your MELD score is under 15 or over 15, your survival exceeds those that have to wait and don't get a living donor liver transplant, either because they have to be transplanted when they're sicker and the risk of dying. Now, one thing, the MELD score has been around since 2002 in allocating organs, and we can see that there's been a slow decline in its predictive power of predicting who is sick and who is going to die. So while the MELD score may have been a very good predictor of death back in when it was implemented in 2002, today is a much lower predictive value than it had in the past. So as we all know, they all have patients who we think are sicker than their MELD score, and this has been shown to be the reason. Now, this was a study that was done by one of our transplant fellows, Joel Webb, and this study was very interesting, and I think something important for you all to realize is that in this study, he looked at everyone on our transplant waiting list who had MELD scores under 20. And at the time, these were people who were never going to get a liver transplant. And then he looked at their stage of cirrhosis, and particularly looked at whether they had had a history of variceal bleeding or ascites. And this figure shows that on the left, we've got people who have no varices and no ascites, and their relative risk of death is 1. Patients who had bleeding varices had an 8-fold increased risk of death compared to those who did not have bleeding varices or ascites. Patients with ascites had a 6-fold increased risk of death compared to those who did not have varices or ascites. And amazingly, if you had a history of variceal bleeding and ascites, you had a nearly 13-fold increased risk of death compared to those who did not have those complications. And these are people who have MELD scores under 20 who are not going to get access to the liver transplant. And that's also been recently noted that sarcopenic patients, or muscle wasting in patients, has an increased risk of death. And this is particularly important and a big issue for women, because women who are sarcopenic have dramatic increases in death compared to sarcopenic men and non-sarcopenic men and women. Now, I did tell you that living donor liver transplant has a benefit over deceased donor liver transplant. However, the experience of the transplant center is very important in considering. And this figure shows you that patients who have a living donor liver transplant at a center that's done more than 20 have an improved survival compared to those patients who have a living donor liver transplant at a center that's done 20 or fewer living donor liver transplants. So experience does matter. Nationally, living donor liver transplant comprises only 4% of all liver transplants in America. The slide here on the right shows the number of centers doing living donor liver transplants and the number of transplants they're doing each year. And you can see that while there are about 35 centers in the United States that do living donor liver transplants, there's only 10 centers that do more than 10 transplants a year. And this shows you a map of where those centers are, and the University of Colorado is one of those centers. This figure shows the liver transplant volume at the University of Colorado since 1988, when our program was officially started. It's worth noting that the first liver transplant was done here at the University of Colorado in 1967 by Dr. Starzl. As I mentioned, the first successful adult-to-adult right lobe living donor liver transplant was done here in 1996. And since 2014, we have done at least 10 living donor liver transplants every year. And last year we did 20 in adults and we did 8 in children. So who should consider living donor liver transplant? I would say anyone who's on the transplant list. If you're sick enough to be listed for a liver transplant, you're sick enough to have a live donor liver transplant. And certainly when patients have MELD scores of over 12, you're going to start to see where the risk of death of having a transplant starts to equal the risk of death of just dying waiting. So anyone with complications of liver disease, especially portal hypertension, bleeding varices, encephalopathy, ascites, spontaneous bacterial peritonitis, and hepatorenal syndrome. And liver cancer. There are mechanisms for people within the Milan criteria to get upgraded on the transplant list. However, it's much harder if you're outside that criteria. And if you have a big aggressive tumor, I'd argue it's better to get that thing out as fast as you can. So living donor liver transplant does offer that to people. And then we all take care of people that we think are sicker than their MELD score would reflect. And those can be people with recurrent cholangitis, refractory pruritus, such as patients with PSC, PBC. Malnutrition, I already showed you, was a big risk factor for death. And then there's some indications like polycystic liver disease where there are just no mechanisms to get transplanted with a deceased donor liver transplant. Who can be a living donor? Well, this is something that you only have to match blood type. So you only have to have compatible blood type to be a donor to someone who wants to have a transplant. Our age cutoffs is between 18 and 55. You need to be healthy with no major medical problems and have a BMI under 30. You have to have a compatible size to the recipient. So a recipient who's 6'5" and 300 pounds cannot receive a donor from someone who's 5'0" and 100 pounds. You need to be psychologically stable. You do not have to be related, or you only even have to know the recipient to have a live donor liver transplant. I will say that I'm going to switch gears here and talk a little bit about altruism in liver transplantation. Altruism is a selfless behavior undertaken to benefit someone other than oneself, and perhaps the most unique form of altruism is to undertake something that is risky to you and provides a benefit to someone who you don't even know, or you're doing it anonymously. Colorado and Wyoming, our organ procurement organization, we do see a population that is very altruistic in that we have some of the highest rates of donor allocation or signing up to be organ donors in the United States. I'm going to share with you a story of a woman that came forward to us in 2017. She was 28 years old, and she approached us saying that she wanted to donate part of her liver to someone who needed it. She had actually already donated a kidney in the same way, and her mother had actually donated a kidney. And she grew up in a very religious household, where she was always encouraged to go out every day and do something good for someone. So we evaluated her, and after a 2-day evaluation, we found, which included a psychological evaluation, we found that she was a candidate to donate. And several weeks later, she ended up donating her left lateral segment to this 1-year-old boy. And today they're both alive and well. And this case is what started off our non-directed living donor liver transplant program. And over the past 3 years, we've had 36 people come forth wanting to donate part of their liver to someone in need. A little over half of the patients that came forward were approved, and amazingly, 10 of these people had already donated a kidney. We've called these double donors, and you can see that 13 of these people donated to a child, and 6 ended up donating to adults. And the number of living donor liver transplants we've done from non-directed donors is about 30% of our living donor transplants that we do here at the University of Colorado. As I said, we started this program giving transplants to children, and this looks at the transplants at Children's Hospital Colorado by donor type. So the first case we did in 2016 of a living donor to a child, and then we did these non-directed in blue. And you can see every year we've done more and more non-directed living donor liver transplants to children at Children's Hospital, such that it starts to represent a majority of the transplants that are going on at Children's Hospital. And now Children's Hospital is the biggest living donor liver transplant hospital for pediatrics in the country. And amazingly, the impact that this non-directed living donor liver transplant program has had on the Children's Hospital wait list has been unbelievable. It essentially has eliminated the wait list, such that we now have donors available for children who have not even come forth to be evaluated. And in this slide, I shows you that there's one person on the transplant list. That one person has an insurance that will not allow living donor liver transplant, or else we have 3 people that could offer a transplant to that child. So this slide summarizes the type of grafts that we've been using in non-directed living donor liver transplants. We did start out with left lateral segment because it's safer. We started doing left lateral segments. We started giving some of those to adults. And then we ran out of kids, so we had to start thinking about who could we offer these livers to. And we did our first right lobe living donor liver transplant from a non-directed donor in 2019. This summarizes where these grafts have gone to. Initially, they started going to children. We ran out of children and we started giving them to small adults, mostly small women. And as I said, the number of people who've already donated a kidney, this has been written up and published by Dr. Jackson, one of my colleagues, is one of the largest live donor liver donations after kidney donation experience in the country. So to summarize this non-directed living donor liver transplant program, with a collaboration between the University of Colorado and Children's Hospital Colorado, it's the second largest published cohort in North America. It has eliminated the pediatric wait list. You know, we prioritize pediatric recipients, especially children under 1, because they don't have a lot of access to transplant. But we're now offering non-directed living donor liver transplant to small adults who are benefiting from this program. So in summary, 1 out of 5 people will die waiting for a liver transplant. And we all know that MELD is not a perfect predictor of who needs a transplant. Live donor liver transplant offers access to transplant. It increases the donor pool for other people. It improves the recovery, and it optimizes timing of transplant. Living donor liver transplant has equivalent survival compared to deceased donor liver transplant. And altruism is highly prevalent in Colorado, and as a result, has eliminated the pediatric wait list. I just share here on my closing slide some of the people that have benefited from live donor liver transplantation. Aaron was an altruistic donor that came forward and donated to Manny, a young kid with biliary atresia. And you can see this kid is totally normal now. Jeremy and Joel they didn't even know each other. And he came forth and just wanted to help this guy out because he went to his church. Claire here is a young girl whose mother donated to her, and she's now thriving. Lindsay is one of our physician assistants that works in our clinic, and she donated to her mother years ago, and they're both doing wonderfully. And finally, Dr. Yaffe here was our transplant fellow. She donated to her dad 10 years ago. Her dad was able to go to her wedding, and now Dr. Yaffe is a transplant surgeon. The only transplant surgeon in the world who's also been a living donor. So I think it's something that is a very unique aspect of the University of Colorado, and I'm glad we're able to help as many people as we are. And I look forward to taking any questions during the question and answer period. Thank you.
Thank you so much, Jay. That was an amazing talk. I personally find whenever I hear our team speak about this experience and everything that's evolved with our living donor program, it just is something that reminds me of why we all work so hard at what we do. And it's really just a bright spot in a crazy world right now. So thanks again.